Bismillahirrahmanirrahim. Today we will discuss rhinosinusitis. Rhinosinusitis is the inflammation of lining of mucosa of nose and paranasal sinuses, and this inflammation can be acute. So there are certain etiological factors like allergy, infection, and certain miscellaneous conditions such as GERD. Some forms are vasomotor rhinitis that are due to hormonal imbalance. Some drugs can induce the inflammation in the sinuses and the nose, and there are certain emotional conditions can cause inflammation, or they can stimulate the seromucinous gland to form more secretions, and certain irritants such as fumes of certain gases or paint fumes and dust particles can irritate the nasal mucosa and can cause inflammation of mucosa of nose and paranasal sinuses. And there is another condition that is called atrophic rhinitis, in which there will be atrophy of the seromucinous glands and the mucosa and even the bone of sinuses. Sometimes allergy can cause inflammation. That is the most common cause of inflammation of nose and paranasal sinuses. Allergy can be seasonal and perennial allergy. Perennial allergy remains throughout the year, and it is due to dust mite, pets, and food allergy. And seasonal allergy is due to pollens. Some patients are allergic to dust particles, to wood dust, and some are allergic to fumes of certain gases and the fumes of the paints. So, drugs that can cause allergies. The infection, we can divide infection into acute and chronic form. Acute form is usually due to viral infections, and then there may be superadded bacterial infection later on. Chronic infection is can divide into specific and non-specific bacterial infection, and the fungal infection can also cause inflammation of nose and paranasal sinuses. And important fungi are aspergillosis and miscellaneous conditions we have discussed. We will discuss this: idiopathic vasomotor rhinitis, drug-induced emotional imbalance, irritants, and one condition that is gastroesophageal reflux syndrome. So nowadays it has been proved that if patient is having chronic gut, can cause inflammation of sinuses. So current classification of infective rhinosinusitis: acute, subacute, and chronic form. Acute inflammation that lasts for less than 1 month, chronic in between 1 to 3 months, and subacute is in between 1 to 3 months, and chronic more than 3 months. In cases of acute and subacute conditions, the mucosal changes are reversible, but these changes becomes irreversible. There will be hyperactivity of seromucinous glands, so there will be formation of a lot of secretions, and sometimes there is destruction of the mucosa. So destruction and healing are taking side by side in chronic inflammation. There will be fibrosis and sometimes destruction of ducts of the seromucinous glands, leading to mucus retention cyst and even the um, so, common pathogens for acute and chronic. In acute, viruses are the most common pathogens: rhino, corona, influenza, and parainfluenza virus. Bacteria which are common in acute inflammation are Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis. Staph aureus is common in both acute and chronic infections. Sometimes Streptococcus pyogenes, that are beta hemolytic, can cause acute inflammation of nose and paranasal sinuses. In chronic form, gram-negative bacteria are prominent, such as Pseudomonas, Klebsiella, and anaerobic infection is also common, and due to bacteroids and anaerobic streptococci. And Staph aureus is common in both acute and chronic forms. Sometimes fungi can cause chronic inflammation. What is the management? Management depends on diagnosis, and diagnosis is based on history, clinical examination, and investigation. Clinical features are almost the same in acute and chronic conditions, but in acute conditions there will be systemic symptoms like fever, body aches, and there will be severe obstruction of the nose. That is, the patient will come with the breathing problem. So, in cases of acute conditions, there will be systemic symptoms. Pain over the sinus, pain in nose and paranasal sinuses is the common symptom of acute conditions. So, there will be pain over the respective sinus. In maxillary sinus, pain will be over the cheeks, and there will be increase in pain when the patient bends his head downwards. In frontoethmoid region, there will be pain, forehead pain, that is frontal headache, and retroorbital pain in cases of ethmoid inflammation. And in cases of sphenoid inflammation, there will be pain. And in acute conditions, there may be swelling over the respective sinus. In cases of maxillary sinus, there will be swelling over the cheeks. In cases of frontoethmoid, there will be upper eyelid swelling, but in cases of maxillary sinus, lower eyelid will be swollen. Ethmoiditis can lead to inflammation of both upper and lower eyelids. So nasal obstruction is one of the commonest symptoms. Then post-nasal drip, due to increased secretion by the mucinous gland, there will be post-nasal drip. Irritation in throat, this phlegm will cause irritation in throat, and there may be acute and chronic pharyngitis. Associated symptoms are common in acute conditions. Cacosmia is the symptom in which there is bad smell from nose, that is usually seen. So, clinical examination. So, first of all, you will inspect. There will be inspection, and there can be swelling over the respective sinus, and palpation. There will be tenderness over the respective sinus. So, in cases of maxillary sinus, when you will percuss the teeth, there will be pain over the cheek, and patient will have fullness of the one is the symptom when patient will feel pain when he will bend his head downwards. So we can, when we will ask the patient to do Valsalva, if there is oroentral fistula in cases of chronic rhinosinusitis, pus will come out of the fistula. So in anterior rhinoscopy, nasal mucosa will be congested in cases of infection and will be pale blue in color in cases of allergy. In cases of vasomotor rhinitis, mucosa will be red in color, that is congested mucosa. So, in cases of infection, acute infection, pus will be seen in the middle meatus, because in middle meatus, all the anterior group of sinuses open in the middle meatus. So, there will be thick yellowish secretions in cases of acute rhinosinusitis. In cases of allergy, secretion will be watery in nature. And then there will be enlarged inferior turbinate in cases of vasomotor rhinitis and in cases of allergic rhinitis. But in cases of infective rhinitis, middle turbinate will be enlarged, and sometimes there is inflammation is seen in cases of allergy. Pale blue mucosa and inflammation and edematous mucosa will be seen in both nasal cavity. And in cases of infection, in acute infection, both nasal cavities will be swollen. But in cases of unilateral maxillary sinusitis, so we can see inflammation only in one nasal cavity. So sometimes there is concha bullosa that is seen in chronic form of rhinosinusitis. That is, the air cells are present in the middle turbinate. So this is the anomaly, can lead to chronic rhinosinusitis. Throat examination will show enlarged retropharyngeal lymph nodes. So there will be granules over the posterior pharyngeal wall. That is the common. This finding is commonly seen in allergic rhinosinusitis. Thick yellowish secretion is seen in cases of infective rhinosinusitis, and post-nasal drip will be thick, yellowish and greenish in color, but in cases of allergy it will be watery and thin secretion. So while examining the nasal cavity, rule out any predisposing factors like DNS, polyps, concabulosa, any foreign body, and so in cases while making the diagnosis, always percuss the teeth. So sometimes if there is inflammation of canine teeth, it can lead to unilateral maxillary sinusitis. So ask the patient to do well salva to rule out any oroentral fistula. Posterior rhinoscopy is done if you are suspecting enterocoinal polyp. Transillumination test, we can put the telescope inside the mouth, and we'll ask in dark room all the sinuses containing air will be illuminated, or we can also put the torch inside the mouth, and in dark room all the sinuses that contain air will be illuminated, but sinuses will contain pus will be dull, and there will be no light will be visible through the sinus. Then rule out allergy, take family history, and you can rule out allergy examining the nasal mucosa. So radiological investigations are very important. Important is plain radiograph of the sinuses. There are different views: lateral view, occipito-mental view, anteroposterior view, and the submento vertical view. But the results are not very good. False positive and false negative results are more common. But this is the cheapest investigation. In lateral view, we can see sphenoid frontal sinus and air fluid level in the maxillary sinus. In occipitomental view, all the sinuses are visible, and we can also visualize sphenoid sinus when it is taken with open mouth. In anteroposterior view, caudal view, frontal and the ethmoid sinuses are visible. Occipitomental view is also called Waters view. Then submento vertical view will show sphenoid sinus and the. So what are the common findings of plain radiograph? Air fluid level in cases if there is pus in the sinuses, mucosal thickening. When the lining of the mucosa is more than 5 mm, we will call it mucosal thickening. That is commonly seen in chronic rhinosinusitis. Opaque sinuses are seen whenever there is fluid, there is blocked ostia, mucosal thickening, fibrous dysplasia, and sometimes previous cardiac operation will lead to fibrosis of the sinus, and sometimes sinuses are underdeveloped. So we can see opaque sinuses. These are the causes of opaque sinuses in the. You can see this is opaque sinus, and we can see mucosal thickening. Reason is mucosal thickening. These are the frontal sinus, these maxillary sinus, these are ethmoid sinus between the nasal bones and orbit, and these are the sphenoid sinus. Again, frontal sinus, orbit, maxillary sinus, septum, nasal cavity, and this is hard palate, and we can see sphenoid sinus through. Again, this is the teardrop sign, that is in blowout fracture, but maxillary sinus is visible in occipito. So hazy sinus, block ostia, maybe cardiac, previous cardiac operation, maybe pus inside the sinus, maybe fibrous dysplasia. So opaque sinus, there are certain points we have to keep in mind. And this is the sphenoid sinus, sella turcica, just below the sella turcica is the sphenoid sinus that is visible in CT scan. These are the maxillary sinus, these are the ethmoid sinus. Ultrasound, if we are suspecting pus in the sinuses, we can do ultrasound. Type B can be advised. And then swab for culture sensitivity. If there is pus inside the nasal cavity, we can take swab for culture sensitivity. And in enteral lavage, That is, we can wash the maxillary sinus and we can collect the secretions of the maxillary sinus for. So it can be diagnostic and as well as therapeutic. It is done through inferior meatus with the help of trocar cannula. So sinoscopy, we can nowadays we can perform sinoscopy. Whatever present in the sinuses can easily be seen with the help of telescope that attached to the camera and monitor. If you are suspecting some mucociliary reaction, so saccharine particle is placed 1 centimeter behind the anterior end of inferior turbinate, and the patient will feel taste of the saccharine after 15 minutes. So this is the normal time. If it is prolonged, it means there is some problem of the mucociliary action. So normal investigations are blood CP, ESR, and then serum Ig level will be raised in cases of allergy. Neutrophils in the blood will be raised in acute infection, lymphocytes in chronic infection, and eosinophils in allergy. Skin allergy test is done when we are suspecting atopy. There is family history is positive, so skin allergy test will be positive. Nasal secretions, we can stain nasal secretion with the help of eosin and hematoxylin, and in cases of allergy there will be eosinophils, but in cases of infection, lymphocytes. So treatment of acute sinusitis, medical treatment, we will prescribe painkiller, non-steroidal anti-inflammatory drugs. Antibiotics are given that are sensitive against these bacteria. So in routine we will in acute cases we prescribe antibiotics without doing culture sensitivity test. But if patient is not responding, then we can advise culture sensitivity test and we can change the antibiotic. We can suspect beta lactamase producing bacteria if amoxicillin, if patient is not responding to amoxicillin. So co-amoxiclav, that is combination of clavulanic acid and amoxicillin, can be given. In cases of resistant cases and if patient is allergic to penicillin, then second and third generation cephalosporins and quinolone. In cases of anaerobes, metronidazole is given when we are suspecting opportunistic infections, such as in patient with immunocompromised patient. Third generation cephalosporin is given. In nasal congestants are mandatory to reduce the inflammation of the nose and paranasal sinuses. So there are oral nasal decongestant and the local nasal decongestant. Local nasal decongestants are in the form of drops and oral contain sodium. So xylometazoline and oxymetazoline are the short acting. They act immediately and they will reduce the inflammation of the nose and paranasal sinuses. So nasal toilet is essential. We will give different type of nasal douching and we will ask the patient to take steam. Okay. Surgical treatment, if patient is not responding to this treatment and there is pus inside the maxillary sinus and there is development of any complication, orbital and other complication, we have to drain the sinuses. So maxillary sinus can be drained through enteral lavage. If we don't have endoscopes, we can drain the maxillary sinus through proof puncture. So only indication of proof puncture is the acute and subacute maxillary sinusitis. If we have endoscope, we can keep the cotton wool soaked in adrenaline into the under the middle turbinate. So it will open the ostia of the sinus and we can drain these sinuses by opening these ostia, or we can also perform middle meatal enteroscopy. So in old time, we do frontal trephine operation to drain the frontal sinus by giving some skin incision just below the medial end of eyebrow, but nowadays these procedures are done with the help of endoscopes through the nose. External ethmoidectomy, if there is development of any complications and patient is developing orbital complications, so external ethmoidectomy, Lynch-Howard incision is given around the medial canthus, and we can approach we can approach the posterior and anterior ethmoidal hair cells. But nowadays all these surgeries can be done through endoscopic sinus surgery. So we have now endoscopes and we drain all the sinuses. Atrophic rhinitis is the condition that lead to chronic inflammation. There will be atrophy of nasal mucosa, turbinates, atrophy of the seromucinous glands, and atrophy of the nerve ending. So the patient will present with anosmia. So ciliated columnar epithelium is replaced by stratified squamous epithelium. It can be primary or secondary. Primary is sometimes it is hereditary, sometimes there is deficiency of certain endocrine and certain hormones. It is usually seen in females. Sometimes it is related to certain autoimmune disease, and vitamin D deficiency is also common in these patients, and infective, sometimes there is infection with Klebsiella ozinii. Secondly, whenever we remove the excessive removal of turbinates and certain diseases, leprosy, tuberculosis can cause atrophic rhinitis, and sometimes radiotherapy can lead to destruction of the mucosa and seromucinous gland. Marked DNS on the one side, there will be unilateral atrophic rhinitis of the other side. So clinical features will be, there will be spacious nasal cavity, foul smelling nasal discharge that is felt by colleagues, because patient will be anosmic due to atrophy of the olfactory nerves. So this thick secretions will produce bad smell that can be felt by colleagues. Epistaxis, lot of crusting will lead. So treatment is removal of crust by means of medical treatment, nasal toilet by means of soda bicarbonate and sodium chloride douching, and we can also give drops in the form of 25% glucose in glycerin to remove these crust. Local application of antibiotic, estradiol and vitamin D3 are also helpful. Old procedure is young operation. We block stitch one nostril for 1 month and then other nostril for next month. So it will help in healing the mucosa, but this is old technique. Nowadays we can reduce the nasal cavity by injecting certain filler, and Teflon injections can also be. Hypertrophic rhinitis is the thickening of nasal mucosa and seromucinous gland and periosteum of the bones. So it is usually seen in chronic infection, chronic irritation, and prolonged use of topical nasal decongestants such as xylometazoline. So this condition is called rhinitis medica-mendoza. Allergic rhinitis can also lead to hypertrophy of the mucosa. So hypertrophic turbinates, there will be hypertrophy of the middle turbinate and also the inferior turbinates. So patient will present with nasal obstruction and nasal discharge. Treatment is medical treatment to reduce the size of turbinate by means of steroid nasal spray, and the surgical treatment is partial and total turbinectomy, SMD, submucosal dithermy, and sometimes linear cauterization can also be done. Latest technique is laser. It will evaporate the turbinate, and sometimes there is cryosurgery, and submucosal resection can also be done with the help of endoscope. So compensatory hypertrophic rhinitis, that is usually seen in marked DNS. Nature reduces the mark patency of opposite side by causing the hypertrophy of turbinate. So inferior turbinate and middle turbinate gets hypertrophied due to space that is provided by deflected nasal septum on other side. So if there is marked C-shaped deflected nasal septum, the inferior turbinate of other side will get hypertrophic. So medical treatment, if not enough, then surgical removal of turbinate. Septoplasty is also indicated. Rhinitis sicca is the condition which is seen in bakers and gold and black semis due to dry weather. This dry weather will cause lot of secretion, lot of crusting inside the nasal cavity, and patient will come to you with epistaxis. So correction of environment, steam inhalation, and nasal diffusion. Vasomotor rhinitis is the condition that is due to imbalance of autoimmune autonomic nervous system, usually seen in old age and usually seen in females. Nasal mucosa becomes hyperactive to certain irritants. So it is usually seen in females, and the smell of certain food can also cause irritation of the nasal cavity, and there will be lot of sneezing and rhinorrhea. So it is different from allergy because in this condition mucosa become hypersensitive to certain irritants, but it is not allergy. And color of the mucosa will be reddish. There will be hypertrophy of the inferior. So clinical features: rhinorrhea, nasal irritation, and sneezing. Differential diagnosis: allergic rhinitis and infective rhinosinusitis should be considered. So then cases of allergic rhinitis, there will be family history, but in vasomotor rhinitis, there will be no family history. Eosinophil will be absent in the nasal secretions. Ig level will be normal, and the skin prick. Treatment of vasomotor rhinitis is almost the same as allergic rhinitis, but prolonged treatment is not indicated. We usually ask the patient to take steam. Antihistamines are also helpful. Decongestant, oral and local decongestant, but local decongestant usually given in the form of steroid nasal sprays. They reduce the sensitivity of the nasal mucosa. So they reduce the irritation of the nasal mucosa with by these irritants. If there is hypertrophy of the turbinate, surgical removal, cautery, and laser surgeries are indicated. Sometimes there is, if there is severe rhinorrhea and these things are not helpful, then Vedian neurectomy. Vedian is the nerve that supply the secretomotor, that contains secretomotor fibers and supply the seromucinous glands. So Vedian neurectomy is indicated. Endoscopic sinus surgery can be performed in to cut this Vedian nerve. And then parasympathetic blocking agents that are not easily available contain anticholinergic drugs are also helpful. Allergic rhinitis is very important topic. So definition is it is type 1 hypersensitivity reaction, and nasal and respiratory tract mucosa becomes hypersensitive to different allergens, and it is usually seen in atopic individuals. There is um, family predisposition to certain allergens. So, allergens are actually the proteins. During at first exposure, allergen enters the body. They initiate immunoglobulin E formation. This immunoglobulin E, IgE, gets bound to the mast cells of epithelium of respiratory tract. On next exposure, allergen binds with this antigen IgE level to the mast cells. So there will be antigen antibody reaction. There will be rupture of the mast cells and release of the preformed mediators. These mediators are histamine, leucotins, and chemotactic factors. And this will cause inflammation of the mucosa, migration of the cells toward the site of inflammation. So this is IgE antibodies and antigen reaction and IgE antibodies are attached to the mast cells. So this binding will lead to degranulation. So what are the action of these mediators? They will cause inflammation of mucosa, migration of eosinophil to the site of allergy, and then hyperactivity of seromucinous glands. They will be more thin. So we divide it into seasonal due to pollens, mulberry trees, grass, fungi are very important. Grass, sometimes patients are allergic to grass pollen, so there will be allergic reaction in hot weather. And if patient is allergic to fungi, he will be allergic in humid weather. And some patients are allergic to pollen, so most of the plants flower in spring, so patient will present with these symptoms in spring season. Perennial allergies throughout the year due to dust mite, pets and food allergy. Sometimes patient is allergic to drug, and more common drug is aspirin. So aspirin allergy to aspirin can lead to severe allergic reaction and even the polyp formation inside the nasal cavities. Occupational allergies, patient may be allergic to paints and wood dust, leading to type reaction. Symptoms, these symptoms are important: sneezing, itching, rhinorrhea, and watering of the eye. In cases of seasonal allergy, there is blackening around the eye that is called allergic shiner. Patient will be afebrile, but in cases of infective rhinosinusitis, patient will have fever. But in vasomotor and allergic rhinosinusitis, there will be no fever. But mucosa of in allergic patient will be pale blue in color, but in cases of vasomotor rhinitis, it will be congested and red in color. Watery rhinorrhea will be seen in both conditions, but in infective rhinosinusitis, secretions will be thick yellowish color. So shiners of allergy are the black circles around the eyes, and patients sometimes mucosa becomes hypertrophic, and there will be formation of. So diagnosis depends on history, clinical examination, then investigations. Important investigations are blood CP. There will be raised eosinophils, IgE levels will be raised, and the eosinophils will be present in the nasal secretions. In atopic individuals, positive. So medical treatment prevention is very important. Avoid allergens by using masks, remove pets from house, use leather sofas, and wet mopping should be done, and keep window shut during spring season or during pollen season, and use filters in cars and AC to avoid allergy to some fungi. And prophylactic medicines can be used: sodium chromoglycate and montelukast. They stabilizes the mast cells, and montelukast also prevent the migration of the cells towards the site of inflammation. Antihistamines are helpful whenever there is inflammation, and steroid nasal sprays can also be used. These if patient is having severe allergy, oral steroids and the systemic steroids can also be given. If there is enlarged turbinate, we can do turbinectomy, and for and endoscopic sinus surgery. So complications of allergy is the formation of polyps, usually ethmoidal polyps, asthma when there is allergy to the low respiratory tract, allergy to the lungs and the epithelium of the lower respiratory tract. There will be inflammation inside the bronchioles, wheezing. Patient will present with respiratory distress and wheezing. So, enlarged inferior turbinate can also be due to allergy. Infective sinusitis due to blockage, it can lead to stasis of secretions, and there will be secondary infection. And this allergy due to blockage of the eustachian tube can lead to otitis media with effusion. And this blockage of eustachian tube can lead to. Thank you.